Good morning, everyone. I'm Dr. David McNiel, Integrated Interventional Radiology resident at the University of Arizona. I'm going to speak today about clinical predictors of Yttrium-90 uptake in Hepatocellular Carcinoma towards personalized dosimetry to maximize response to therapy. These are our group's financial disclosures. Radioembolization with Y90 microspheres is a commonly used procedure in the treatment of hepatocellular carcinoma. Typically, methods for calculating dosage is based on pre-radioembolization planning procedures using MAA as a surrogate. These methods fall into semi-empirical models and partition-based models. Recently, the Dosisphere 1 trial reported improved response to therapy and overall survival in patients that underwent personalized dosimetry calculation. We performed an IRB-approved retrospective review of patients who had underwent MAA planning angiography between September of 2016 and the end of August 2020. A multitude of relevant patient characteristics were harvested from the electronic medical record and subsequently, using a personalized dosimetry tool provided by Murata Medical called Simplicity, co-registered this data to calculate uptake of MAA. During the study period, we identified 106 patients who underwent a total of 128 MAA planning angiography sessions. A number of procedures were excluded from subsequent analysis due to technical factors in relation to missing imaging, incomplete imaging, misadministration of MAA, and inability to accurately delineate borders of tumor. We subsequently utilized the Simplicity dosimetry software to co-register SPECT imaging obtained following MAA administration with pre-procedural MRI. Of note, there are two general methods of performing this type of co-registration: anatomically based and physiologically based. In this study, we utilized an anatomically based co-registration method where we calculated manually the borders of tumor in 3 dimensions and subsequently used those borders to calculate the activity of MAA both within this tumor and within the surrounding normal liver. T to N ratio was subsequently calculated based on the activity within the tumor divided by the activity within the surrounding normal liver, normalized to their respective mass. Our initial hypothesis with this work was that T to N ratio would be significantly correlated with the etiology of patients' cirrhosis. Surprisingly, however, this wound up not being the case, and despite the apparently diverse group of patients that go on to develop hepatocellular carcinoma, including patients with NASH-based cirrhosis, viral etiologies of cirrhosis, and alcoholic cirrhosis, none of these groups demonstrated significant differences in T to N ratio in our dataset. Similarly, clinical factors that we anticipated would likely have correlation with T to N ratio, including Child-Pugh classification, prior surgical resection of tumor, and prior systemic chemotherapy, also demonstrated no significant differences in T to N ratio in our dataset. In terms of the positive results, liver-directed therapy, that is prior intra-arterial directed therapy, including prior Y90, prior TACE, and prior ablation therapy, demonstrated significant positive correlation with T to N ratio in our dataset. Tumor volume, while not significantly correlated, showed a strong negative trend. That is, larger volumes of tumor apparently took up less MAA activity than their smaller counterparts. This finding is likely artifactual based on our methodology, as larger tumors are more likely to contain necrotic, poorly perfused components, and thus they are likely to take up less relative MAA than their smaller counterparts. Patient age was negatively correlated with T to N ratio on univariate analysis. However, on multivariate analysis, demonstrated non-significance. This is likely on the basis of collinearity of other variables. Subgroup analysis of patients who had underwent prior liver-directed therapy also demonstrated interesting results. What we considered liver-directed therapy included 2 subgroups, that is, patients who had prior intra-arterial therapy in the form of prior Y90 or prior TACE, and patients who had prior ablation therapy. Interestingly, patients who had prior intra-arterial therapy demonstrated no significant difference in T to N ratio, whereas patients who had prior ablation therapy demonstrated a strong significant difference in T to N ratio, which was positive. These findings raise interesting questions. Specifically, is there some different mechanism of ablation therapy versus intra-arterial therapy that affects this activity? Also, is recurrent disease following either of these therapies somehow inherently different in their angiogenesis or their aggressiveness that could explain these findings? These are references for this project.